Okay, so welcome everyone for today's teaching session. We've got the fantastic Miss Sancy Low giving us some teaching on cataracts. I'm going to pass you straight over to her because it sounds like she's got some really interactive and some enjoyable teaching for us today. So Miss Low, if you wouldn't mind.
Hello, I hope you guys can participate in some of it. If it's very noisy, maybe not muting, but those who are willing to shout out answers, it's going to help us draw our cataract patient. And I'm going to be trying to use this classic whiteboard teaching because to jazz things up and see if we can get more engagement at 7 p.m. on a half-term week. So thank you so much for a big turnout. So we're going to talk about a couple of things with cataract surgery because number one, we're gathering number one as a community. So we want to talk about the service itself. So within the service, we've got in Southeast London, we've got St. Thomas's Hospital, we've got Queen Mary, Sidcup, and King's College Hospital and all the subsidiary places. Those account for probably at the moment about 60% of cataract surgery. But this is kind of declining towards 40% because as we know, there are also other independent sector providers in the area. So I'd like to talk about two types of stratification. We've got risk stratification and for the patient, for the list, and for the service delivery. So most of us live and work in Southeast London, particularly yourselves, and your patients that you're referring in London might be a more transient population than, say, Dundee, because I'm actually lecturing from Dublin, having just come from the Belfast meeting of the Royal College of Ophthalmologists. If we take all cataract patients put together, you'd have 30% in the green zone, 30% in the amber zone, and 30% in the red zone, right? This is what we would consider complexity. Does somebody want to shout out what's a green cataract? Why would we say something was green? What are we thinking about when we're saying green or low complexity? Anybody want to shout out? So when we have complexity, we're looking for I factors, we're looking for person factors, and we're looking for environmental factors. Okay, and the biggest environmental one is the distance to your location. So I'm sure that you guys have preferred providers of where you send your clients to, because convenience and traveling and parking are all kind of considerations for the surgery itself, right? So even though it's a lecture topic on cataract surgery, as a community gathering, it's quite important for us to think about what other things we talk about in optimizing the best fit of surgery to the locality and to the outcomes. So we're going to talk firstly about the service, and then we'll talk about the surgery itself, where I will show you some videos and how we therefore prep for the surgery and then pass the referrals through. Are you guys hearing my kids shouting? Is it very noisy? Okay, no, that's all right. Okay, so the complexity is shifting in the sort of within the hospital setting. So this was what we had before the pandemic. Probably the low complexity to the medium complexity was about 70%, but it's flipped over so that the high complexity is now more than the 70% in the hospital setting. So we're talking about something like this, where we've got 30% simple now. And then down here with the 70%, we've got here. Sometimes they're traveling a long way because they've already been rejected from the independent sector provider because they need GA, they need sedation, and those are the things that can only be provided for here. Okay, so the reason we're engaging with the optometrists, etc., is to make sure that when we teach and we stratify for the complexity and how we refer our patients and we go through the journey. It's appropriate and it's medically relevant. We are also losing our nurses. So now all the local anesthetic pre-assessments are being lost. So this green zone here are typically local anesthesia, right? And 90% is local anesthetic, even though the case is complex. Can you see that? So the case complexity might be 70% complex in all of these hospital settings. And when we mean complexity, it's these two things that we're talking about, right? With the eye and the person. So there are a lot of models around the country, and at the Royal College of Ophthalmology, there were many meetings with this. You might have heard of this acronym before. These guys, quiet. It's called Get It Right First Time. So the government wants us to get it right first time by matching the correct provider with the correct level of complexity of cases and the correct level of care. So now we have 90% of patients needing local anesthetic procedures and maybe 2/3 of the patients that are complex. And what do we mean by complex? There's actually a way of stratifying it. So we can stratify ocular complexity and person complexity. So this is what we call comorbidities. And everyone's familiar with these, right? So on your cataract referral forms, you want to talk about type 2 diabetes. You want to talk about language barriers. So communication. Yeah, you want to talk about previous trauma, amblyopia, etc. Everything that we're actually doing is talking about risk. Is that fair? Yeah, talking about the person is talking about the risk. And the ocular morbidity, actually, there are places around the country where it's bypassing the hospital service completely. And the optometrists are listing the patients direct for cataract surgery. And the two main things they really look for are things like Fuchs, glaucoma, other pathology. Why? Because the actual cataract surgery itself, whether it's a 1+ nuclear sclerosis or very, very dense cataract, the actual workup itself, the most problematic is somebody with Fuchs, because you can damage the eye and go down an entire series of corneal decompensation, loss of vision, and it's adding to that level of complexity. So we need to match that with subspecialty services. Is that all? Everybody sort of still following from the sort of environmental overview point of view? So I've actually been thinking about this a fair bit, and now I don't know how to erase my whole page. Let's see if I can just get a new page. Sorry, it's my first time trying to do this. So new whiteboard. So what I came down to with 3 things that we need to talk about, it's 3 words, which is feed, flow, and follow up. Right? So the feed is where we're together as a community. And even within St. Thomas's Hospital, we've got different types of lists. So you can have different individuals. This one is 55 years old and he's driving. He's got counting fingers as one eye. Okay, but maybe he has trauma. You've got a female, 74 years old, also driving, 618. You've got another one in a wheelchair. I don't know how to draw a wheelchair, but very vulnerable, language barrier. And let's say 88 years old, dementia. Okay, so they feed in all the same way, isn't it? At the moment, you make the same referral and you put in the key points. And most people's attention spans are like, okay, what are the key things? We can spend all our time writing down everything about every single patient. but we know that our outcomes and what we wish for each of these different patients is different, correct? Because this could also be first eye or second eye. And this one might be end of life. Or maybe not. Or maybe has got good care. Okay, and the single most important thing for outcomes of any surgery, and particularly cataract surgery going like that, is social support. Okay, and I've been thinking very hard about how we transform this service, because right now the independent sector are doing between 50 to 60% of our cases, and they're taking these guys, right? These simpler cataracts. Let's see if I can get a different, yeah, right. But there is a kind of process going through. So we want to increase that back up to 60% in the hospital. And the feed for this and this are completely different. And how you refer to that, you might tweak. You might have the same form that you fill in with farm outcomes, and you always check vision, correct? You all do VA, you all do refraction, you all do your IOPs, etc. But from the hospital vetting side point of view, you want to know that this guy needs to get back to work. Needs pounds, the sole trader, sole person, whatever, working person. So remember during the pandemic, we used to stratify particular patients. Yeah. And so 618 was kind of the mark. Even though there is no criteria to say 6 and you can't refer, because somebody 6 their vision might be 6-4 normally, and they're affected by glare. So sort of the NHS referral service doesn't give you the sort of granularity of how much contrast sensitivity is lost. It's not got a 25-minute discussion about motivation for surgery like it is refractive, but it's still within our remit to try and get the best refractive outcome, control the eye pressure, not miss glaucoma, not miss corneal changes, not miss Fuchs, because those ones then downstream can end up in corneal transplants, etc., and lots more follow-up, and also not appropriate for you to do the follow-up. So the flow of the patients going through this will mean that we have to do something called high volume cataract surgery, which is causing a lot of discontent or a lot of debate at the Royal College of Ophthalmologists, because what is high volume? In Dundee is 12 in 4 hours. Okay, can you imagine putting 12 of these guys in 4 hours? But that's the proportion of work, which is the feed. So one of the things I'd like people to think about is, if you're involved with the single point of access, or you've got straightforward, simple cases, remember that we're teaching hospitals, so feed them back to the teaching hospitals, because our trainees depend on it, and we want to do this high flow work, but it has to be a stepwise thing. We can't do 12 on every single list because we can't train our trainees, but we can do 12 if, let's say, a combination of these feedback to the hospital at about 60%. If we don't get 60% or so where we can train up and produce a feed, then the hospitals will suffer. And it's actually a economics thing. That means that people who need biological treatments, those people who come in with brain tumors, those people with severe sarcoidosis and they need our medical eye unit, or the long-term glaucoma care that doesn't pay very well, just won't get done, because we need the cataract service to feed through. So one of the things we called is, as a collaboration, is a Cataract 1000 project. At least at St. Thomas's, we do 2,500 per year. Okay, when we do 2,500 per year, if we try and rescue another 1,000, basically increase to 1,000, because the national standard of doing cataract surgery is about 8 per list, which is every 30 minutes we change the patient. Every 30 minutes, we have to change a patient. So not only does the surgeon need to get that slick, or us as the consultants, we need to do that safely. And remembering that all these patients come in different shapes and sizes. And for example, this 70-year-old lady here might have a leg ulcer, which is actually the topic of the consultant WhatsApp chat this afternoon. We were debating what to do with a leg ulcer. How do we coordinate the leg ulcers? Firstly, we give moxifloxacin, of course, so that we give an antibiotic that kills the bacteria. But the process itself needs for us to be able to always look at the person, the eye, and the environment. So that's kind of the service and the logistics of how we do cataract surgery at St. Thomas's and how we deliver it and how that shape of that is changing. A little bit of a pitch to say, don't just send all the hospital difficult cataracts. The things that you should send to us as well are things that we know we do well at St. Thomas's. We're a big cataract research unit. So we have toric research studies, we have enhanced depth of focus lens research studies, etc. We need 300 or 400 patients just to keep those studies alive. So feed through that, but write down, even though it's an NHS setting, you need the motivation for surgery. How is it impacting the patient? For example, the one who's working and needing to pay his bills for the family, the 55-year-old. And then the 74-year-old, maybe it's 6/18 in both eyes, but she's got a leg ulcer. Why is there a leg ulcer there? The leg ulcer might be because she's diabetic and a chronic vasculopathy. So we kind of need to know that because the CMO risk, the cystoid macular edema risk is high. So suddenly she's no longer in the green zone, she's more in the complex zone, where we certainly cannot do both eyes together. And we also have very few cases where we do immediate sequential bilateral cataract surgery, because they'd have to have perfect corneas with no astigmatism, no likelihood to make them worse. They need to have, they're typically not Afro-Caribbean, because Afro-Caribbean people have more inflammation. And then you've got this big pool of the ones that possibly cannot have consent. So from our point of view, when you put in the referral letter, to make it simpler for us, needs a nurse or technician. There are two types of clinics. The nurse-led clinic means these guys here, because they have a need to talk to a nurse, whether it's district nursing, to look at the leg ulcer, to organize their diabetes, or maybe have a diabetic review. So you would say something like, please see the 74-year-old with your nurse-led cataract clinic, because doesn't speak English, blah, 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 has already lost one eye from a complication done in Africa somewhere, something like that. You know, please can they see a consultant? So even in the feed, you do all your usual stuff like your normal referral. I'd like you to start thinking about who you would like this referral to actually get to. Is it our trainees, where they can do lots of surgery and get really good, so that when we get cataracts, they'll be trained up to do that? Or do they need to go to one of the projects I'm running, is something called Vision Together, and that's a team of geriatricians. So the Vision Together list and the Cataract 1000 lists are separate lists, so that we can scale the sameness of the feed to have the complex cases together in one and the really simple cases in another, because that allows us to then fix our flow. Once we have flow, and we can get, right now, we do better than some other centers in the area, and we do about 4 to 6 per list. Okay, this is with trainees, and probably the biggest compliment we had this year, at least from my point of view, was 2 retinal fellows caught in a lift with me. And they were saying, you know, Miss Low, it's really, you know, we've been here 8 months at St. Thomas's Hospital, and like nobody's dropping nucleuses. We've not had a single drop nucleus. We've not had the chance to fix a complicated cataract. And for me, that was just like, wow, that means we're really doing a good job, because you saw how I drew out that 70% of our work is now the really tricky stuff. So for the retinal fellows to say, we've not seen many of your complications from within internally St. Thomas's Hospital, that is a really good vouch of confidence that this is a really good unit where the standards are high, even though we've been in transition with Epic. And for about 6 months, we can't even communicate properly with you guys. Like when you used to send us our results back from Open Eyes, I think our follow-up is at the moment in a little bit of a risky position because MECS does maybe at the moment 20 to 30% of hospital follow-ups and perhaps 70% of the ISP follow-ups. So, we can look at our outcomes, we can look at our results, but from a service point of view, I'd like you to just think feed flow follow-up, suitable to see back in MECS or this patient that we know. So that is already on the referral letter that we can have different types of clinics to say these are routine cataracts, no comorbidity, suitable for technician-led clinic, and division is 618. Or this one is complicated at a much higher risk, definitely needs a nurse. Remembering that 90% of our patients will no longer see a nurse because they'll see a technician and they'll see a consultant-led service where we try and filter them into different lists. Some of them will have 8, some of them will have 12. So I now need a new whiteboard. We go now to the clinical aspects. So why is understanding the service important for delivering the clinical aspects? Because I think you guys also have that in your clinic. Sometimes when you're interrupted doing something, if you're doing all day, all afternoon of MECS, for example, or you're doing something else, you can get into a zone. For example, you may be sitting in a glaucoma clinic and that same person's been told they've got ocular hypertension, etc., or an advanced glaucoma case, and we've missed the fact that it was a bitemporal defect until somebody else looks in. So from the clinical point of view, the more we can repeat, one of my bosses used to say, simplicity multiplied gives us complex. So I'm extremely confident that us as a major teaching hospital at St. Thomas's and probably the longest standing minor eye condition scheme in the city, in the country, we've got really deep roots despite being in a very diverse multicultural city, that I reckon that we can really deliver high quality cataract surgery where every list has about 8. It allows for training. It allows for us to audit, and it allows for us to communicate back. And the communication can mean going back to our commissioners to say, hey guys, we need this, but we also need injections. We also need glaucoma, etc. And we have to think about comorbid states in clinical. So on Adana's brief, she also wanted me to cover the ideal referrals to make sure that you say things like, so just now when we talked about service, writing interpreter, writing transport vulnerability, just do the top 5. We know that you always send in the visions and clinical data because most of that is just automated for you. But the top 5 things you think that the hospital needs to know, like available at short notice, for example, you can put that, or needs to contact daughter, or needs a district nurse, something that would make their journey in cataract surgery important and smooth. I think that this group here is mature enough as clinicians that you can pick the top 5 things. I think this one has Fuchs sent to the corneal clinic to consider cataract surgery. Something like that, put your top 5 things and then list the risk factors. Because we know the risk factors include the eye healing slower. So things like previous uveitis, trauma, amblyopia, and cystoid macular edema or uncontrolled diabetes. Past medical history, usually that falls towards the social side of things as well. So the social side of things, we kind of covered in that little picture of that lady in a wheelchair. Sometimes it's really useful to get the next of kin phone number. And that's particularly that wheelchair person at the top, especially when they are unable to consent. Because this is where the community comes in. They might not be able to consent, but you've known them for a while, or you've known the family for a while, and you might be better placed than us to tell us of something, which is that very first thing that all private providers always ask, which is the motivation for surgery. Okay, so for the 5 things that you should talk about, motivation for surgery, the social aspects such as driving, things that can change their livelihood, things that can change what they do daily. Then we want risk factors, common things like diabetes, etc., uncontrolled BP, for example, you know, something that might slow us down with our one-stop service. What was the other things? Risk factors, past medical history, and then transport. These are kind of logistic issues, but it helps us because we can put the patients then in 2 separate clinics. You guys know about the mini kid house. Yeah. So we've got a center now in South Clapham, and that's going to increase because it's our Clapham. How do you spell Clapham? P-H-A-M. Something like that. So it is our intention and our hope to bring back the flow for our patients, which mean for our patients and our trainees, which means we have to increase the flow. And now that we've got biometry and actually facilities to do diagnostics at South Clapham, we may actually do some of the more complex patients once a month or once every 8 weeks there. So being able to flag to us, particularly those of you who already contribute to the single point of access service, kind of think of those top 5 things. And then the ocular ones, like I talked about, Fuchs, glaucoma, blah, blah. And then sometimes you're referring people that have already had complications, right? How many of you identify with that? Already complicated. Do one of you or some of you want to shout? What difficulties have you seen that you want to send back to the cataract clinic? No one speaking? Okay. PC rupture is the #1 complication. You know what that is, right? That is the posterior capsule of the back of, as we do the cataract inside the eye. So there are some types of cataracts that are posterior polar. Okay, this one comes under the ocular complication that we want to know about. So this is called a posterior polar cataract. It's different from a posterior subcapsular opacity. A posterior polar cataract has a 25% risk of a rupture. So this needs a senior surgeon. Okay, and this is congenital, and this would be typically younger, and this would be 55-year-old, thereabouts. And the reason I've put 55 here is because it's an important age to remember. Do you know there are people who are doing lots of lens exchanges to get rid of glasses, spectacle free? That is potentially dangerous advertising because, of course, there is a motivation for surgery component to that. But if you start to operate on patients younger than 55 years old, particularly the male myopes, your RD risk goes up 10 times. Yeah. So age is always age, driving status, occupation, ability to consent, language, how they're going to get to us, what they expect from us. Those are the key things that go onto your referral, together with the standard things, what tablets they take, what medication, etc. We're trying to make it simpler for you, and actually a Southeast London-wide Epic software, we're not quite mature enough there yet. But eventually, the very complex patients will have everything pre-populated. So it should take us less time to do all their drugs and stuff like that because we have a shared computer system. But in the meantime, we have what we have to deal with. So there are some patients that we need to be more aware of because expectations are higher now. Okay, so what am I talking about with expectations? So have you ever seen patients who have come in, they've got 6/6 vision and they're not happy? That's in the realm of the refractive surgery. One of the reasons they are not happy is cannot sew. Right? That's why motivation for surgery, telling us what they need to do in their day-to-day life is important. That's how we meet that expectation and get it right for the patient. First of all, our big job is not to have a complication. So we avoid doing the young ones, we avoid doing the myopes. And did you know that men have more complications than ladies? Because what we've got now in the UK is something called the NOD audit, National Ophthalmic Database. So you can look up any surgeon, you know, they'll typically have between 100 to 6,000 operations. I looked up somebody and they did 6,000 operations throughout their pandemic. So, wow, clearly very slick because they're doing so much all of the time. And as a pool of community, we want every able cataract surgeon to deliver to their best standard in the most appropriate list with a most appropriate group of patients sent to them by the service, because this is all provided for by the National Health Service that we pay for with our contributions. So the NHS should be equitable. It should have high quality, and it should be safeguarded by ourselves. Okay, we want it to continue. We want our grandmothers to have surgery. We want our grandmothers to have great surgery, but everybody gets plano, right? Refractive outcome. So we talked about the 5 things that I'd like you to sort of tell us to help us with our services. But the other thing you're expert at is the refraction. So in this day and age now, you've got right eye, left eye. Typical axial length is about 23 millimeters. Okay, or 23.5 millimeters for a male and a female, okay? So axial length is important. And then when you've got K readings steeper than 45. So you might not do that, but you might, because you might have fitted them with contact lenses for a long time, right? So one thing that would really help your local hospital is to tell them that if you're being referred for cataract surgery, the contact lenses need to come off. 5 days for dailies, 14 days. Usually, if you don't know, just say 14 days, but some of them will really struggle, right? And it's something like 1 week per month of RGP contact lens. So if somebody's been using RGPs for 10 years, it's like 10 weeks. You know, one every year of RGP lenses, it's you really need quite a long time for the cornea to bounce back. Doesn't mean we can't do the biometry. But the other thing, apart from knowing the history of the patient, is the measurement, because cataract is a delivery of a perfect refractive, or a good enough, rather, a functional, good refractive outcome for the patient. Just like that lady I told you about that's really bitterly unhappy because she loves sewing and she started at -2. Okay, that's the bit I think you guys are really comfortable with and really, really good at, because you might already have been fitting them with multifocal contact lenses for some time. So one of the things you can tell them is when you get your hospital appointment letter, please don't wear your contact lenses for 14 days, typically. Yeah, but if it's just daily disposables, soft contact lenses, 5 days is sufficient. 10 days is sufficient for monthlies. As a rule, if you don't know, they don't know what type of lenses, or you might not have known, or you are a local meta practice, or if it's RGP, so these then are converted. So when I see these ones often come to me privately because they are so dependent on their their refraction, and they're really struggling in their 60s, and high myopes get cataracts earlier. So what we do then is to move them to soft dailies, and then you move them back to the 2 weeks. So these are active things that you can do planning for the patient. For example, they've got early cataract. So they're early cataract because they are type 2 diabetic, maybe. You can give them advice. You can refer to GP to manage the diabetes. And let's say they're only 52 years old, but they're female. You know, the 55-year-old male myopic risk is higher. But the younger patients have got longer time to need the cataract to be perfect for. So this 52-year-old might live to 95 years old. You don't know if they're going to get glaucoma. You don't know if they're going to get AMD. You don't have a crystal ball for the future. But you can tell them their risk factor needs to be controlled. You can tell them they've got early cataract, and let's say they're -6 and -4. You can use that, couldn't you? They don't need surgery. Just because you've seen a cataract, you don't have to send them through yet, because we know that the more mature the eye is, the better it is, because we're looking for PVD. Yeah. So when we're seeing them in clinic and we've got them dilated to check for the sort of technical bit, which I think we do very well at St. Thomas's, myself, Seema Verma, and Elodie Azan, we check everybody's biometry. They may not see a consultant for many parts of their journey. They might see me once, and then the next 10 episodes are no longer with me, and they'll be with Sanjeev, the nurse consultant, or our optometrist. Seema has a big team. Friday afternoon is a big team of optometrists, but we've looked at that. And then at the biometry, at this stage, we will ask them to print the biometry for plano and 1.50, because we know that people can usually tolerate up to -2 diopters of anisometropia, right? So that's the technical side of what happens when your patient comes to us on the day of the surgery. So if our communication starts earlier, tell them about contact lenses, don't wear them to your cataract assessment visit. And on the day of your cataract assessment visit, they'll be planning a lens for you. The lens is usually for distance, because most people are happy being able to see for distance. But when we have a totally suitable candidate for bilateral cataract surgery, which I said is about 20% of our population, so 20% of our cases would be bog standard. 70-year-old is the typical age in the UK for cataract surgery. They are 70 years old, they've got nuclear sclerosis plus, they're fit and well, they're still playing golf, they look after their grandchildren, etc. You know, so those patients exist, and they can have bilateral surgery on the same day. Those people that have bilateral surgery on the same day, what we do for them is typically plano for the dominant eye and -0.50 for the non-dominant eye. How do we know dominance and non-dominance? Sometimes you don't know, except look, -6 and -4. Which one is likely to be the reading eye? Probably the -6. Yeah. Or you might know because you fitted the contact lens. So you can tell us that this patient is suitable for monovision because they've had dominant vision, and that way it stops the hospital from making the mistake of making everybody completely zero, which used to be the case. And even now, over the years, we've started making people zero and minus plano on the dominant eye, and then the research study that we've just finished is doing plano on the dominant eye and -0.75. Why is that? This is outcome, right? Why is that? Because most people use computer screens, iPads, and phones, and mobile phones, and they might live to very, very old. They might get dementia, and they need to see their plate and their food on the table. If you make everybody plano, it might not work quite so well. So this is an increasing recognition, and that is also why the technologies and the lens companies have started making these new implants. Some of them are zonal, like the convivity, is actually almost like a trifocal lens. And like I said, you don't know if somebody's going to get glaucoma, except you might know there's already a family history, or you don't know if they're going to get AMD. But 50% of AMD patients have some drusen or already known a family history. Doesn't mean they can't have different lenses, because like J&J, the other study that we have just finished is called the eye-hands lens. Yeah, this one we're doing them plano dominant and non-dominant minus 0.75, and what we're getting is N8 unaided vision. So as an institution, we're pushing the boundaries. We're saying, okay, everybody should have cataract surgery. Did you know that the majority of cataract patients undergoing cataract surgery in the UK, I think there's a published national study, about 30% of patients will have significant astigmatism. About 5 to 10% that astigmatism is more than between 1.5 up to about 5 diopters of astigmatism. And we all know that there could be a disease or problem here, isn't it? When you've got so much astigmatism, you might have keratoconus. Okay, so that goes in your referral, because we want intelligent referrals. Please send to the corneal team to consider cataract surgery because this patient has keratoconus. Is now stable, or had cross-linking, or didn't have cross-linking, or there's so much haze and the central cornea query need a transplant, right? And we know that the transplants are like more than 1 year at the moment. And the transplant for the keratoconus is out here, whereas the transplant for Fuchs is down here. Correct. So we want intelligent referrals. We want your expertise, which means we want to know if you've been looking after them for more than 10 years and you know their dominant eye, or they have a lazy eye. And sometimes with the lazy eye, we just do immediate sequential surgery, because the most important one to do is the sighted eye. Yeah. And we don't ever do trifocals. Very rare. The trifocals do really well with the very small eyes, because it's more likely that, you know, the axial length in a long eye, and you've got 3 zones, you're going to get more of this kind of pattern and light scatter. You have a lot more scatter, you have a lot more glare plus, but you don't get it so much if it's a smaller eye, you see. So there is something bespoke about choosing lenses, and patients are getting more intelligent. Certainly for a high quality NHS service, we need to think about a little bit of monovision. So if you know about the dominant eye, you know that they're contact lens wearer, tell them not to wear their contact lenses, and then come in, and then typically we give them good distance vision, because I think that we can achieve 90% 6/12 spectacle independence almost, but we of course never promise that. There is complications, like real proper complications like suprachoroidal hemorrhage and stuff like that. But the biggest complication that we find in cataract surgery is expectation not met. That is the most difficult one, because
Can I interrupt you quickly?
Hmm?
That's okay. I'm just conscious of the time. I wonder if we would be able to move on to the question section.
Yep. The questions of complications.
Well, I just wanted to invite our viewers to see if they've got
capsulotomy.
any questions. I've got a question, if that's okay.
Yes, of course.
Often when we're talking to our patients about cataract surgery and referring them onwards, we do talk about the average statistics in terms of risks, because the patients obviously want to know, you know, how risky is it? So what sort of things should we be saying to people, you know, 1 in 1,000, those sorts of things?
Always 1 in 1,000 for sight loss. We always say that. And sometimes it's 1 in 500 if you know that already something's happened before. And that's kind of previous surgery, RD, guarded prognosis, etc. That is the headline theme. And then you have to say the 3 to 5% risk, because that's the average, but some of them are less than 3%, and some of them are more than 6%. And that's kind of how I drew the complexity. So someone with more than 6% risk would be the ones like the polar cataracts, for example, yeah, or the Fuchs, or the very small eyes, or the very vulnerable. So we don't have lots and lots of classification. We just have more than 6, 3 to 5. If you're not sure, again, like the 2-week rule for contact lenses, it's 5% risk. And then you tell them about macular edema. And then you just tell them that you don't go blind if there is a complication. So we call it a technical issue. Because in a technical issue, 1 in 100 need another operation. And when they have this technical issue of another op, again, the likelihood of success is pretty good. But 20% need a laser. And you know what that laser is? YAG. Yeah, it's not completely without risk, but it's still worth telling them, because that's what they will call them like secondary cataract. It's not really a secondary cataract, but it's the membrane around the lens implant itself. The implant sits there and that becomes cloudy. So, and then what we do is YAG laser it. But then, you know, in a patient with glaucoma and too much energy, you get high IOP, you can have retinal detachment, you get cystoid macular edema. Remembering that the eye only knows 1 or 2 ways to react. If you hurt and injure an eye, the worst thing you have is a massive bleed and expulsion and everything comes out. So suprachoroidal bleed is 1 in 1,000. Right? Or you have a leg ulcer, you rub the leg ulcer, you go to the loo and you don't wash your hands and you rub it on your eye. You get endophthalmitis. That is 1 in 1,000. Okay, and then otherwise, the smaller things are these guarded prognosis. And if you cover these 3 statistics and cystoid macular edema, where you say you need 8 weeks of eye drops, we can still get 90% of our patients 612 or better. Especially when we deal with the 30% to 50% where there's a bit of astigmatism. You sit on the axis, you just do very simple things from a surgical point of view that we teach. Then as a unit, our refraction outcome is slightly tighter than nationally. Nationally, most people come back with more astigmatism. You send somebody in with a minus 1.5 on your refraction. When they come back to you for your post-op check, you see them minus 2.25, minus 2.5. You know, and they're coming in to get glasses, and that's fine, but we could have made that 2.25 go down to 1.75. So that is why we cannot think of cataract surgery in isolation. Think about it as a service, and your local service and your local trusted provider, because your voice is important. If you're seeing, hang on a minute, you guys have loads of uveitis, tell whoever and escalate and goes up there. Or lots of astigmatism, etc., so that we as a service gets better. And it also makes it more interesting than a didactic talk of, you know, just cataract surgery and, oh, this is uveitis, this is, etc., etc. So I think that's covered the complications, it's covered management.
One more question, if that's okay. In terms of treatment post-operatively, moons ago, I was told by Sarah Janakoon that she wasn't happy seeing patients for YAG within 6 months of their cataract surgery. Correct. Is that still correct? Is that, and why is that, if I can? Yeah.
So because, like I said, the cataract, they're still breaching a membrane inside the eye, which means you can still cause inflammation. So in the old glaucoma studies where Dilani Suri-Bardina was looking at flare following cataract and trabeculectomy surgery, and it went on for more than 6 months. So you can reactivate uveitis. You can, if the posterior vitreous hasn't fully come off. So typically, if the patients haven't had a full PVD, you do the cataract surgery, quite soon afterwards, they'll have the full PVD. That's why people see floaters and more floaters afterwards. So those are the smaller print that they might say, you know, you might get ptosis because of the clip holding the eyelid open. You could have floaters because the inside of the eye clears up, then you see them more often. So these are the less common things that are complications of cataract surgery. But for the YAG, you want it to mature for at least 6 months so that you're less likely to cause a reactivation of the uveitis and also allow the natural PVD to have occurred. Yeah, ideally you wait 3 years because that's a bit like the average age for surgery is 70 years old. So most of our 80-year-olds should be treated. If they're like 79 and no one's talked about the cataract, ask them what they like. They'll say, yeah, their vision's fine. It might look like 6'9", but there's something, because we don't want them to become 95 years old and no one's ever treated something that's preventable. And for the YAG, 20% will have it. If the cheaper lenses are used, like the hydrophilic lenses or poor quality lenses, you can even see posterior capsular opacification like within 2 months. You know, and it's affecting the patient, but we can clear it out. However, we can clear it up, and I have seen people have chronic high pressures or uveitis or damage to the lens, 6 months, ideally around 3+ years. And then it's the flow thing again. And then Miss Azan has a clinic, which is a YAG clinic. And then that goes down to our computer systems where you can book it on ERS. I think I've gone on for more than the 40 minutes that I've allocated.
We've
I'm
stretched
sorry
the time
about that.
out a little bit. Does anyone else have any questions? Please do unmute yourself and ask if you have any questions, or type in the chat if you're not comfortable adding questions.
Yeah, can I just make a comment, please, as part of the referral? If the patient, do consider referring the patient, if they've already got a comorbidity, ocular comorbidity that's being treated somewhere, please consider referring them to the hospital that's already managing them for that condition, okay? Because it makes it so much easier. So if they're having under glaucoma for us already, and they have a new, you notice they've got their symptomatic cataract, then do refer them to the hospital they're already under. Yeah. And the other thing I would say, like Sancy touched on already, please be aware that patients get very anxious when you mention the word cataract. So they think of it as like a disease, like it's some kind of cancer in the eye that needs to be removed straight away. Please don't refer them for cataract surgery if they really have no symptoms, are not bothered at all. Okay, unless there's a medical indication for the surgery. If they have no visual something, don't go on about it, because they just get really worked up about it, and then they come in all panicky. But I don't really want anything. I don't have anything, but my optometrist said I have a cataract and I need to get something done. So just be a little careful about the wording when you're talking to them, because you might say it in a very matter-of-fact way, and they just read the sort of the worst possible outcome, and it means I have to have something because I've got this disorder that needs to come out. So that's the only thing I was going to say.
And one last thing with our videos was I don't know if you've seen our videos at St. Thomas's. When you do Google and you search GSTT cataract surgery, then you will come to this page that says overview, and on the overview page, there's a 2-minute video. And that 2-minute video tells me whether people can do LA or GA. If you've got somebody super anxious and you're saying, oh, really needs sedation or something GA, you play that video. They typically, or if they cannot consent, their family member will tell you they would be able to do LA or GA. So I think there is definitely a processing. Don't need to send people just because you see a cataract, is what Adana's saying, right? And when they already have an existing place, just say in bold, already under King's glaucoma. So that vetting person will just put it to King's glaucoma, or that single point of access person can put it in to that correct place, because it affects our feed and our flow. If we can't get our feed and our flow through, then your waits are going to be longer and we can't get them back to you for MECS, etc. So the kind of logistics as well as clinical are both kind of linked.
Yeah, brilliant.
I think that's that. So we should go to our peer review.
Yeah, I'm just going to stop recording if that's okay. Ms. Low, are you okay to stop your screen
Yes.
share?
Yes. Was that good, or would you prefer me to sit down and make slides for